Hi, my name is Navina. I'm one of the doctors working in Nottingham Trust. I'm just going to teach about liver function test, how to interpret it, and hepatitis as well. And this is sort of more catered for the MSRA exam. So hopefully by the end of this presentation, you'll be able to interpret the liver function test and the hepatitis B screening bloods. So I think it's important that when we to just categorize the liver function test. So first, when you look at the enzymes, you sort of need to conclude whether it's hepatic in nature. So the predominantly the ALT or the AST would be raised. Cholestatic in nature, so the ALP or the GGT would be raised, or mixed. So you can't see if either the ALT or which one is more raised, basically. Then you go on to see the synthetic function, and this sort of comes down to what the liver does. So the liver produces clotting factor. So you look at things like platelet, you look at their prothrombin time. So platelet production would be reduced, prothrombin time would be raised. And then you look at protein. So albumin and total protein would be reduced in someone who has got sort of chronic liver disease, and bilirubin production would be increased as well. And then you also do the non-invasive liver screen, which includes the ultrasound scan. And then, so someone who has deranged liver function test, it could be due to metabolic syndrome. So you do fasting lipid profile or HbA1c. And then there's autoimmune conditions. So you do immunoglobulins, autoimmune screen, and the celiac screen. And then there's infection. So you check hepatitis screen, HIV screen. And then things like hematochromatosis. So you check for ferritin, but ferritin is also an acute phase reactant, so it's not very reliable. So usually if ferritin is deranged, you go on to do iron studies. And then you do ceruloplasmin or copper. However, ceruloplasmin or copper is usually used to diagnose Wilson's disease, but it's only it usually happens to any people who are under the age of 40. So people who are over the age of 40, you wouldn't test ceruloplasmin or copper. So just breaking down the liver function test. If someone has predominantly raised AST more than their ALT, then you think it's either alcohol related or it's an advanced fibrosis. If it's ALT that's much higher than the AST, then it's hepatitis. If it's ALP or GGT that's raised, it's cholestatic, so it's extra hepatic, so you think it's biliary in origin. It could be obstruction, infiltration, or congestion. And then the antibodies, I've just focused on the ones that have repeated questions on. So the anti-mitochondrial antibody would sort of make you think that it's primary biliary cirrhosis, or the anti-neutrophil cytoplasmic antibody that would make you think primary sclerosing cholangitis. And then you've got immunoglobulins. So you have got the IgM, which you would think primary biliary cirrhosis, IgA, alcohol, and IgG, autoimmune diseases. So here's the first question. So in this question, if you look at the blood test, you see the AST is raised as well as the ALT, but the AST is much higher than the ALT. And the gamma glutamyl, the GGT is raised as well. So you think alcoholic hepatitis. So in alcoholic hepatitis, like mentioned before, AST or GGT would be much higher than the ALT. And you manage alcoholic hepatitis with steroids. So the next question. Okay. So for this one, so the patient has presented with vomiting, right upper quadrant pain, jaundice, and he admits to a relapse of alcohol misuse with an alcohol binge 24 hours prior. So the AST is 260. His ALT is 101. So you can see that predominantly the AST is raised. And you know that his synthetic function is also deranged. So the INR and platelets are deranged and the albumin is low. So in this question, the answer is actually steroids. And so I get that the vitamin K could have thrown people off. But if this thinking that it could be sort of an upper GI bleed. But if there was an upper GI bleed, they would state that they would give the urea results, so a raised urea, They would also mention that patient has had vomiting. They will mention about the content of the vomit, either a coffee ground or a bright red blood. So yeah, so that's why this is steroids, because it's alcoholic hepatitis. So just a quick tip. So in the exam, I think the most difficult thing to sort of tackle is timing. So I would sort of recommend reading what the question wants first and then going and looking at the case vignette. At least you sort of know what you're looking for and not thrown off by any other information that's given. Okay, so for this one, so most of you got it right, is ascending cholangitis. And I can understand why some people put pancreatitis. So I think obviously it could be a chronic pancreatitis, but this is a 2 months history, and because they've got the Charcot's triad of jaundice, right upper quadrant pain, and fever, you think that it's ascending cholangitis. Not many patients with pancreatitis would actually present with jaundice, one. And secondly, if someone actually did have pancreatitis, their amylase would be much more elevated than this. So Charcot's triad, ascending cholangitis, right upper quadrant pain, jaundice, and fever. Okay, so this next question. So in a 38-year-old woman who's having pruritus and jaundice, so you see the bilirubin is deranged, so their synthetic function is deranged, and you see that the ALP is much more higher than the ALT, and they've got positive antibodies. And this would be primary biliary cirrhosis, because primary biliary cirrhosis would have positive anti-mitochondrial antibodies. So just remember, so primary biliary cirrhosis tend to be in middle-aged women, and they can present with pruritus, jaundice, and ALP, as mentioned before in that case vignette. And it can be related to a few autoimmune conditions as well, like rheumatoid, Sjogren's, and celiac disease. So they would typically have anti-mitochondrial antibodies, the M2 subtype, and they'll have raised IgM. So when you test for the immunoglobulins, the IgM would be raised. And you treat them with ursodeoxycholic acid. And what this does is it improves the progression of the disease. So it slows the progression of the disease, and it improves the patient's symptoms. And then cholestyramine actually elevates the itching. So when patients have got a lot of pruritus, you can prescribe cholestyramine. Next question. Okay. So for this question, the answer is ursodeoxycholic acid. And the reason why I put this question is I think people tend to confuse between answering cholestyramine and ursodeoxycholic acid. And it's just to make sure that you know which would be the management for the condition itself, and which, if they say what would be the most appropriate management for patients' symptoms or to alleviate their symptoms, then you would put cholestyramine. But if it's to manage the disease itself, then it would be C. Okay. Next question. Okay. So in this question, they're asking for diagnosis. So when you read the case vignette, it tells you that their ALT is a bit high, but that's the only information that they've given. But they've given a list of medication and the patient's BMI, which tells you that the patient could have a metabolic syndrome going on. And if you look at their alcohol consumption, they are within sort of the recommended range of alcohol consumption. So they have non-alcoholic liver disease, fatty liver disease. So with non-alcoholic fatty liver disease, it tends to happen in people who have metabolic syndrome, and they can have things like raised BMI, they can have raised triglyceride, cholesterol, so they could be on medications like statins, or they could have diabetes. So the first line to investigate this is to do an ultrasound. So because these patients their liver can basically progress to have necrosis. So make sure that you do ultrasound, and then you can also do a fibroscan to just make sure the extent of the fibrosis, and biopsy if needed. Next question. Okay. So the answer for this question is Wilson's disease. So if you read the question, it's a 23-year-old person, so it's less than 40. And they have unsteady gait, memory loss, a bit of neurological finding, and also their liver function test is deranged and they've got low copper level. That should already tell you that it's Wilson's disease. Now, Wilson's disease means there's increased copper deposition, and it usually it can deposit in liver, causing hepatitis, cirrhosis. It can deposit in the basal ganglia, causing dysarthria, dystonia, or symptoms like Parkinson's, and even in the kidneys, so things like Fanconi syndrome. And some of the findings that you can find is the Keshe-Fleischer ring, so that is copper deposit in the membrane of the cornea. And how do you test this? You check for their ceruloplasmin, blood, and copper levels in their blood, and it will be reduced because they're being deposited in all these organs. And how you treat it with penicillamine, and that is basically a chelating medication, so it will remove copper. Okay, next question. So the answer for this is the anti-neutrophil cytoplasmic antibody. So this patient, I think, so if you read the question and it says diagnosis, it's asking for diagnosis, and then you see a history of ulcerative colitis with jaundice and right upper quadrant pain, raised to bilirubin and ALP. So you think it's primary sclerosing cholangitis, which can have ANCA. So usually primary sclerosing cholangitis has got an association with ulcerative colitis. So they tend to happen in a middle-aged man with ulcerative colitis, whereas primary biliary cirrhosis tends to be in middle-aged women. So these patients can have, basically what happens is they have fibrosis of the intra and extrahepatic duct. So on ERCP and MRCP, you would see beading because one area would be fibrosed and the other area would be dilated, basically. So yeah, they would have PNCA positive. Okay, so try this question and then I'll explain the hepatitis bloods. So the answer is previous hepatitis infection. I'll explain how to interpret it, then we can go through a few other questions and it will probably make sense. So with the hepatitis screening blood, so first you look whether a patient has got surface antigen positive. So if they've got surface antigen positive, then it's either they have so if it's positive, then they have an infection, or if it's negative, then they don't have an infection. So let's say they've got surface antigen positive. Okay, so they have surface antigen. Then you think about the IgM and the IgG. Forget about the surface and the core at the moment when they have positive surface antigen. If they have immunoglobulin, so IgM is an acute immunoglobulin and IgG is a chronic immunoglobulin, so it'll be raised in sort of chronic conditions. So if someone's got IgM positive and IgG negative, that will tell you that they've got an acute infection. Okay. If they have IgM negative and IgG positive, then they have a chronic infection, which means the antigen is still present, but the acute phase has lapsed, and now the body is being able to produce this chronic immunoglobulin to be able to fight the infection. Okay, so if surface antigen is negative, then you think it's either the person has had a previous infection that there's no more surface antigen, but there might be some antibodies, or the person has been immunized before. So now you bring in the factors of whether it is surface or core. So if you think about it, if you think of the virus as two concentric circles, the core and the surface, the virus has to get through the surface to get into the core and replicate. So if the antibody against the surface is present and the one against the core is present, that means it's a previous infection. So the virus has gone through the surface and the core, and the body has been able to sort of produce immunoglobulins against this, therefore a previous infection. And okay, and then if let's say the surface immunoglobulin antibody is positive, but the core is negative, then you think immunization, because the vaccine that we get is for the antibody for the surface IgG. That's what we get. So if you think about it, it's so that basically it's to avoid, you give a vaccine and that will produce that immunoglobulin to avoid the virus from getting into the surface, through the surface to the core, so you will have the positive surface antibody. So now we'll try this question. So for this one, okay, if we break it down, so it's asking for diagnosis. So this person has got a core antibody, but the surface antigen is negative. So we go step by step. So if the surface antigen is negative, it could either mean that they are immunized or they've had a previous infection. But the immunization is only against the surface one and it's not against the core. So if their core one is positive, therefore it is a previous hepatitis B infection that is now cleared. Okay, so the next one. Okay, so if we go through this step by step again, so their antigen is negative, which could mean two things: previous infection or they've had immunization. And then if you look at their antibody, so the antibody for the surface antigen is positive, but they don't have any against the core antigen, so it's not really breached into the cell to replicate and then produce the antibodies. Therefore, this person has been immunized.
Alright, so today I thought we'd just do a quick whistle-top tour of the NICE guidelines of how we manage type 2 diabetics and what order of medications we use, thinking about the contraindication side effects, as well as the HbA1c targets we should go for. So just to kick things off, I think to keep it interactive, we'll just start with a question. So you investigate a 67-year-old gentleman who's complaining of polyuria and polydipsia. His random blood sugar is 11.6. What's the most likely diagnosis from the options below? Okay, and I think pretty much everyone's got the right response. That's correct. So the answer is A. He's type 2 diabetic. The reason why he doesn't have impaired glucose tolerance is if your random BM is greater than 11, then you've definitely got the type 2 diabetic range. Prediabetes is based on an HbA1c threshold, and likewise impaired fasting glucose. We've got a random BM here, so he's not had a fasting glucose test. And why has he not got MODY, maturity onset diabetes of the young? Because this is quite a rare thing. Type 2 diabetics is very common. I'm sure you see a lot of this on the ward. And there tends to be a strong genetic history in MODY. So it's part of a cohort of patients who have specific genetic mutations that disrupt their insulin secretion. And the vignette normally is the patient's a lot younger. We've got a 67-year-old gentleman in this question, so he's not quite a sparkly young gentleman anymore. And normally you'll have also phrases such as a strong family history of diabetes, and they tend to be on their investigations to have normal ketones. Ketones aren't mentioned in this question stem, but remember, common things are common. So if you're trying to decide between it, I mean, it couldn't not be MODY, but because common things are common, the most likely answer here is type 2 diabetes. Okay, so how do we diagnose type 2 diabetes? This is relatively very straightforward, but just a quick through two criteria or two thresholds you can use. Either the patient presents symptomatic, so these are symptoms they could have, such as weight loss, fatigue, recurrent UTIs, and they're also found to have abdominal blood sugar levels, of which there are 3 different tests. The most reliable and the most common one and the easiest to remember is probably HbA1c, and it needs to be greater than 48 to be considered if the patient is also symptomatic to have type 2 diabetes. The thresholds for fasting BM and random BM are a little bit harder to remember, but one thing I remember, if any of you guys have been to Asia, there's a lot of 7-Eleven corner shops around, so if you enjoy snacking, you have a lot of snacks, and thus if you have a fasting BM of greater than 7, or a random BM of greater than 11, you're more likely to reach the threshold of having type 2 diabetes if you're also symptomatic. Of course, there's also the idea of impaired fasting glucose and impaired glucose tolerance. These aren't necessarily required to give a type 2 diabetic diagnosis, but they are just thresholds to remember. So I think don't focus on remembering these exact numbers, but focusing on fasting BM needs to be greater than 7 and random BM needs to be greater than 11. So if fasting BM is close to 7 but not quite 7, they've probably got impaired fasting glucose. And if in their oral glucose tolerance test, which is basically the patient fasts and then they have 2 hours after being given the glucose challenge, it's between 7 to 11, they probably have impaired glucose tolerance. And then just going back, for patients, the other criteria, if you're not symptomatic, for instance, if you're having a well-being test, or maybe a patient has a strong family history of diabetes, or maybe you're looking at gestational diabetes, if the patient is asymptomatic but have deranged investigations, you need two samples, and it needs to be of the same test to confirm persistent hyperglycemia and a formal diagnosis of type 2 diabetes. So HbA1c levels, the main thing is greater than 48, you're type 2 diabetic, but if you are between 42 to 47, you're considered pre-diabetic nowadays. And this is typically managed in primary care by education, lifestyle advice, and for patients who are being continuously monitored yearly with their HbA1c not improving, these patients can be started on metformin treatment. So you might see patients in real life and possibly in the vignette, but realistically, the questions you're going to have in the MSRA are going to be a lot simpler, where a patient who has an HbA1c less than 40 might be on metformin. But just another thing to bear in mind, HbA1c is not suitable for all age groups. So again, that might be a question and be like, what test would you use for a patient with sickle cell disease? So such as in hemoglobinopathies, you wouldn't want to test HbA1c to confirm diabetes. So in these groups, you might use a impaired fasting glucose level or impaired glucose tolerance. Okay, so moving on. The initial management actually for type 2 diabetes is always conservative. The classic stepwise ladder we use in medicine, so from conservative to medical to surgical, which isn't as relevant, but the same idea. So we want patient education, and some people can just control their type 2 diabetes without any medication, such as changing their diet and exercising more. And nowadays, Desmond is a structured education program we can use for patients to optimize their type 2 diabetes. And we also want to ensure there's individualized care. Okay, so next question. A 58-year-old female was presented with 3 months of fatigue and 4 episodes of UTI in the past 6 months. Her fasting glucose was 8.1. She was convinced on 500 milligrams of metformin BD. What would her target HbA1c be? Fantastic. So I think the majority of you guys have got the correct answer. So her target HbA1c will be 48. Firstly, there is no target HbA1c of 42. But between the ranges of 42 to 47, you would be considered pre-diabetic. So this patient is symptomatic and she has got a fasting glucose of greater than 7. So between those two criteria, she's got a diagnosis of type 2 diabetes. And she's already commenced on medication. So if conservative measure fails, how do we manage type 2 diabetes? We'll discuss on that, but the 3 HbA1c targets we need to know is if a patient's confirmed type 2 diabetic, their first starting HbA1c target is 48 millimoles per and this is the target if the patient either just managed conservatively on lifestyle measures or they're on single non-hypoglycemic drugs such as metformin, which is what this lady has. But if they're started on 2 or more diabetic medications, or they started on drugs that causes a drop in your blood sugar, which in this case would be glycoside, their target HbA1c is increased to 53. And if medications isn't improving and maybe they're on triple therapy drugs, which we'll touch upon next, their HbA1c targets increases further to 58 millimoles. So there's not a lot of numbers you remember for type 2 diabetic management, just 48, 53, and 58. Okie dokes. Our next question. A 47-year-old woman is commenced on metformin for type 2 diabetes, so quite similar to the previous question. After 2 weeks, she complains she's unable to tolerate metformin due to diarrhea. What would you do next? So I think most of people have got the correct response. So the answer is C. So the next question. So we've got a 60-year-old female with a past medical history of emphysema and congestive cardiac failure who is complaining of feeling tired all the time. HbA1c of 56 with an eGFR of 56. What management would you give for this patient? The majority have got the right answer. The answer is E. Okay, so I've created a stepwise ladder of how to think about type 2 diabetes drug management if conservative measure fails. The first thing we give is always give metformin, unless you've got really impaired renal function, but normally you start with reduced dose if they've got reduced EFR, and you gradually titrate that up. Of course, the classic side effects are GI upset, so if they're having diarrhea, GI discomfort, you titrate them to modified-release metformin. But the NICE guidelines nowadays says for patients who are at risk or have established cardiovascular disease, you just also start an SGLT2 inhibitor once they're established on metformin treatment. Hence, that previous patient who has a history of cardiac failure, they will also be started on metformin plus the gliflozin. Next, if their HbA1c is still greater than 48, our initial HbA1c target, despite being on metformin, we need to increase the treatment, and there's various options you can pick. And which we can pick, we'll discuss later. You need to balance the individualized plan of the patient with the pros and cons of each medication. And if their HbA1c target now is greater than 58 millimoles because you're giving them 2 or more diabetic drugs, then although your HbA1c target at this point would be 53, you need to start them on triple therapy or insulin therapy. And if that isn't working, so they're on triple therapy and their HbA1c target is at the higher threshold now, 58, what do you do? So you can then start them on what is quite trendy nowadays, one of the GLP-1 mimetics. So anything sensing glutide, so liraglutide, semaglutide. GLP-1 mimetics are very much second, or in this case, third line drugs. It's not your first option of choice. They act very similar to DPP-4 inhibitors. They act in the same pathway, but just at different points. So if you do start them on a GLP agonist, remember to stop any DPP-4 inhibitors you've put them on. And these patients that most benefit are the ones who have a large BMI, so metabolic syndrome, or weight loss would actually benefit general comorbidities, such as other things you think about, maybe hypertension or hyperlipidemia, and also maybe for those who insulin treatment is not a suitable option, such as drivers where DVLA have specific guidelines to minimize hypoglycemia causing driving accidents. And you would maintain them on GLP-1 receptors, so these glutides, if you're shown to effectively reduce the weight loss and also improve their HbA1c levels. Remember, if you're on the 4th tier now, your HbA1c target will remain at 58. So I've just quickly summarized the NICE guidelines. So, as I mentioned before, patients who are on metformin, that's basically first line for everyone, unless they're not tolerating it. And these patients who have a cardiovascular risk, if they're not tolerating metformin, the first option choice you use is the gliflozin. If they are able to tolerate metformin, you do metformin plus gliflozin. So, who are these patients at cardiovascular risk? There's 2 groups. So those who are established cardiovascular disease, or they are established heart failure, or they have a high Q-risk score of greater than 10%. And these patients, you'd also want to put them on a statin as well. And obviously, if they have established cardiovascular disease, whether ACS or heart failure, you put them on a higher dose of atorvastatin. Another thing to consider is patients who are diabetic with impaired renal function, so reduced EFR or they have proteinuria. You also put them on gliflozin to improve their outcomes from a cardiovascular perspective as well. And you also, of course, put them on an ACE inhibitor to minimize proteinuria for patients with kidney function disease. As well, I just put an aside for lipid modification. Any type 1 diabetics, regardless of their Q-risk score, if they're diabetic for more than 10 years or they're older than 40 years of age and they have the established renal function disease as well, so diabetic neuropathy, so you've got a raised albumin to creatinine ratio, you also put them on a statin as well. So just as a quick summary, I've put drugs. These are the drugs, not insulin treatment, that patients would be on. So what I've done is summarized it is that on the right-hand side are drugs that are known to improve or reduce your weight loss, and they're not to cause hypoglycemia. So the classic options are your gliflozins, like we mentioned, are good for patients with cardiovascular disease, either at risk or established, or you want to reduce their weight because it will actually help with their other comorbidities. Your first option are normally the DPP-4 inhibitors, which are gliptins. So you have to base on the same pathways in the GLP-1 agonists I mentioned right at the end, but this is sort of a later line option. So firstly, you try them with the gliptins. They work on the same pathways, so the incretin effect, especially what happens is when you eat, oral glucose activates incretins being invested in your small intestine, which increases insulin secretion. So you get that blood sugar in your blood being hoovered inside, so you have reduced hyperglycemia. So the DPP inhibitors basically stop DPP-4 enzymes breaking down, so they maintain more incretins in effect, whereas the GLP-1 mimetics mimic the incretin effect to artificially produce more incretin, while DPP-4 inhibitors naturally prevent incretin breakdown. So two drugs that are increasing weight are the sulfonylureas, the glycosides, and the thiazolidines. So these drugs are not as popular because increasing weight will be poor for your other diabetic comorbidities, and sulfonylureas is the only one to cause an increased risk of hypoglycemia. So also, again, caution in patients who are DVLE licensing, such as HGV drivers, because you want to minimize hypoglycemia. As well, thiazolidines increase weight gain by water retention, so not ideal for patients who also have known heart failure. And there's a risk that's classically in MCQ of patients with bladder cancer. You want to avoid giving these pioglitazones, etc., to these patients. And another thing is macroscopic hematuria is a red flag for bladder cancer. So you want to avoid giving these medications as a second or third line drug to these patients. So you've got a 60-year-old with type 2 diabetes managed with metformin and dapagliflozin. So he's on 2 drugs already, but this is actually the first line treatment because he's got a past medical history of heart failure. So his HbA1c is beyond 48. The target that we want is 61, despite good compliance. What drugs do you want to give next? Okay, so the answer is B. And I can see why people went for liraglutide, but the reason we've not is firstly, we can discount A and C. Anything ending in antazone, so thiazolidazone, like we mentioned, is bad in heart failure, so ignore A and C. So then we're left with B, C, and E. So we've got a large patient, his BMI is 33, so we don't want to cause any more weight gain, and sulfonylureas increase weight gain, so we've ruled out D. So we're left with B and E. And like I said, GLP-1 mimetics, so anything in IDE, these are more lateral line options. So we want to go for the DPP-4 inhibitors first because that's more higher up in the nice ladder. And if they're not responding well to DPP-4 inhibitors as part of triple therapy, we can then consider GLP-1 mimetics. Thank you very much for your time. And likewise, so we want to thank our sponsors. Based on your feedback that you really like practice questions, we've been hosting these webinars. So Revised MSRA offers a 48-hour free trial for those that would like to access their website. And PassMed, if you scan a QR code now to become a beta tester, you can also get 3 weeks of free access to any question bank of your choice. And this includes the MSRA. Thank you guys, and thank you all joining. With that, goodbye. And thank you, Navina, as well.
Thank you. Take care. Bye-bye.